Last in November at our last meeting, Marty Rosenberg, Project Director of Rhode Island State Innovation Model Test Grant, gave us a presentation on patient engagement. In her presentation, she gave us a brief background on the SIM, the State Innovation Model, or System Innovation Model, excuse me, including its many partners, the goal, how to provide better care with smarter spending, and ultimately having healthier people. She elaborated on 3 categories supported by the SIM funds. That's practice and workforce transformation, patient empowerment, and data capacity and expertise expansion. She invited us all to join the mailing list to receive public notices and updates. If you haven't done so, I encourage you to do so. And if you have any questions, you can email Kat. And Kat, thank you for preparing for this meeting here today. And let me welcome you again to the Special Legislative Commission to study the topic of health literacy. We have 2 key items on the agenda for today. I'll just address that, then we'll get into the meat of the agenda. The first item is about health literacy and patient engagement. We have Jay Burdick, Program Outreach Coordinator for United Way 211 in Rhode Island. Followed by that, we'll have a roundtable discussion on the priorities that were identified and handed out at from the October meeting, and then we'll talk about a meeting for our next date and any public comment. So without any further ado, we'll move on to the discussion about health literacy and patient engagement. And welcome, Jay. You can just make certain the button's up, you'll be good.
Good afternoon. Is it working? Okay. My name is Jay Burdick, and I am the Outreach Program Coordinator at United Way 211 in Rhode Island. I'm assuming everyone here knows about 211, but in case you don't, I'm going to tell you a little bit about it. First, I'm going to tell you a little bit about myself. I worked 33 years for the Department of Human Services, doing many of the tasks there as caseworker and as supervisor, and my final job there was I was the administrator at DHS for Housing and Homelessness. I left there and worked for 2.5 to 3 years for the Diocese of Providence, running their senior programs that they had. And I left there and I worked for another 2 years for a number of unions doing community organizing and union organizing. So the joke in the office is I've worked for the state, the Catholic Diocese, and the unions, clearly a trifecta in the state of Rhode Island. United Way 211 in Rhode Island is a program of the United Way. It is part of a system across the whole country of 211 programs. There are 211 programs in every state, although not all of every state is covered. Most of them are United Way programs, but not all of them. In some of the jurisdictions, they may be run by the government, or they might be run by a different nonprofit organization. In Rhode Island, we are active 24/7, 365. We are multilingual. We have about 10 different languages right on site at United Way, and we have access to a translator line that we use that has another 153 languages. As a small anecdote, about 2.5 years ago, I did a 211 call in Croatian. That was really a very interesting call. We work off a database of services for residents of Rhode Island. We have about 4,000 different services listed in our database. Within the past couple of years, we've entered the 21st century, so you can call 211 from any phone in Rhode Island. Just dial 211, just like 411 or 911. But in terms of entering the 21st century, you can also go to our website, and you can do a search on your own on that website. We also now have a chat feature, so if you're doing a search on the website and you have a question, a little screen pops up, and you're talking to somebody by chat back at 211. And now we also have text. We have a phone number that you can text questions into us on. We also see a great many people in what we call walk-ins. So people know where we are. We're in the United Way building right in Oneyville. People will just walk in to ask a question or to have an appointment with us. Most of the things that we're talking about on the phone with people or in person is basic needs. So we're talking about food, shelter, housing, furniture, clothing, But we're much more than that. Many people think that we're only a low-income focused organization. We're not. So we have people calling us on just about any service that might be available within the nonprofit or governmental or faith-based world. So we have questions that people call us on educational opportunities, on counseling, on support groups. Just about anything. Like I said, we get calls all the time on just about anything. In 2015, which is the last year we have our statistics for, we received 203,500 calls at United Way of Rhode Island, of which 79,195 were for health-related issues. We have a couple of basic tenets that we use at United Way 211. We try to provide what we call wraparound services. So if someone calls, we're not just like 411. We don't just give them a phone number and say goodbye. We try to talk to them, try to engage the client, and they might be asking for something that we don't have, some financial assistance that isn't available to them. We will then try to engage the client on the phone or in person and try to find out maybe they're not on the SNAP program, or maybe they're not receiving energy assistance, or maybe there is a state or a federal financial program to help them out. So we figure if we can save them $1 over here, they might be able to use that $1 over here. Maybe it's for utilities or for rent or something like that. So we call it wraparound services. Again, we try to engage the client in a way that brings to the surface what the problem is. Many of our callers are people who call for one thing, but they're really asking for something else, and that takes a little bit of work on the part of our benefit specialist to kind of dig down and figure out what it is. Our second basic tenet is on self-empowerment for the clients. So we try to give the client as much information as possible so that they can handle the situation themselves. So if somebody calls me about a Social Security problem, I'm going to give them the best possible number I can give them at Social Security. But I'm not only going to give them a phone number. I'm going to say, when you go, this are the questions they're going to ask. Maybe you want to go instead of calling. Be sure to bring these documents because they're going to look for them. So we try to get the client as prepared as possible before we just send them off to take care of their situation. That's mostly the 211 part of our program, but 211 system in Rhode Island is much bigger. We have a number of contracts that provide services for residents also. Our biggest one, and Megan's here, so she can tell me if I'm saying something wrong. Our biggest one is called The Point. Now, every state in the union has an aging and disability resource center. Usually they are set up on a county basis. In Rhode Island, we're not, for obvious reasons. So in Rhode Island also we had to name it. We don't call it the Aging and Disability Resource Center. We call it The Point. The idea being that it is the one point of contact that seniors or adults on disabilities can go to get information on programs or services that might be available to them. It's a separate staff, but they're right next door to us from the 211 callers. So I kid about it because I say if I'm getting a call and I'm on 211 and it's something that really needs to go to The Point, this is how the referral works. Hey, Judy, you got a call coming. And that's as simple as it is. So it is really one point of entry, no moving clients around to different places. This is a contract that we have with the Department of Elderly Affairs, and we work very closely with them. We also have what we call Point Partners, which are point-trained people across the whole state. So if a client really can't do it on the phone and needs an in-person appointment with someone to work on an issue, we can send them to somebody in their own community who can work on them. It's a little bit more strenuous than just the 211 because we can actually help solve problems when we're working with The Point. It will be, as I used the example of the Social Security call earlier, we can't do that all the time because we can't, I kid about it in the office again, that I'm not going to send an 85-year-old lady who does not understand the bureaucracy off to Social Security to solve the problem on her own. So what we will do often is have myself and Social Security and the client on the same phone line. And in those cases, I act as an interpreter because I interpret little old lady language with bureaucrat language. They're not talking the same languages to begin with. It's a wonder anything ever does get solved. But with me getting in the middle and trying to help them out, we can get more accomplished that way. With the point cases, we can keep them for, we call it short-term case management. It may be 15 minutes, but it might be 3, 4, 5 days. We also take referrals for the state's subsidized home care programs. We take those actual applications right at the point. And so we do a higher level of service with seniors and adults on disabilities. And I also want to mention that it's a lot of the calls we get are from caregivers. So it won't be just the seniors or the adults themselves that are calling, but caregivers will call. And they're kind of interesting calls because we've got a lot of calls from people who never had to look for services in their life. They would find everything was going along wonderfully, never had to ask for any help from anyone. And last week, Mom fell down the cellar stairs bringing the laundry and broke her hip, and now we're into hospitals and rehab and nursing care and home care, and the daughter has no idea what Mom has for health insurance and how that whole system works. So we work an awful lot with caregivers to help them with their parents and with others. One of our objectives is improving positive health outcomes, and that's across the whole agency. We have a number of other services that we provide right through 211 through contracts. One of our larger programs is also, if you go buy a lottery ticket somewhere in Rhode Island, you're going to see a sign somewhere that says "Problem Gamblers, call this number." That's us. You're going to reach somebody at 211. We have trained staff to handle issues with problem gamblers and gambling addiction. Bright Stars is a program where we can help people with finding childcare, and we actually answer the phone for them, so people can call us and say, "I need childcare for a 3-year-old from 7 in the morning till 4 in the afternoon," and I live in the 02909 zip code, and we can provide that resident with a list of all the different options for them in their area. We've recently started and gone up in. We've gotten more work to do in the homeless diversion area through the state. So people who are families who need emergency homeless shelters call us, and we work with them to get them into shelters. And recently we've gotten another contract where we're going to be doing the same thing with single individuals. And the whole idea is that maybe we can provide them with the resources they need to avoid a stay in a state shelter. We're also we work on outreach with Health Source Rhode Island, and we're starting in a couple of weeks, we're going to be doing the VITA program, very important program for us. That's the Voluntary Income Tax Assistance Program. So we will be working with people throughout the whole state to provide free income tax preparation services to residents. We also have a number of people on staff. About 8 of the people on staff are actual SHIP counselors. That's the state health insurance program or the senior health insurance program, depending on who you talk to. And it's the program that helps people get into Medicare-related health insurance programs. We also have a number of people on staff who are navigators and assisters within Health Source. So we can actually see clients, we do it all the time, actually see clients and help them sign up for their health insurance, either whether they're senior or not. My particular role at 211 is as the outreach coordinator. So we've always done different forms of outreach. We wanted people to know about 211. And as that kind of evolved, this year's our 10th anniversary. We'll be celebrating our 10th anniversary as 211 this year. As the outreach evolved, we started doing more and more actual resource provision to clients. So sometimes we go out and it'll be like a health fair, and we might just have a table set up to let people know about 211 and the point and our other programs that we run. But usually we would have a computer with us, and that computer hooks back up to 211, so we can actually sit down and talk to clients. Didn't always work out when we went to like health fairs or heritage festivals or that kind of stuff, but it was something, and we were out there doing it. We also do a lot of presentations like this one. The presentation I'm doing for you right now, it's the same presentation I do across the whole state to groups of staff members for organizations or at senior centers or with veterans groups to let people know what 211 is and why they can call us and what kind of services they can get. And in terms of the empowerment, I'm also going to tell them what to expect when you call, like I did with you guys. So it's all the same thing. But we 2.5 years ago, we received a great gift. We received a 38-foot recreational vehicle from Blue Cross. They didn't need it anymore, and so I've got a picture of it. It's 38 feet long, and it's set up as an office inside. And so I use this all over the state. I travel all over the state, and I'll go to events like health fairs or heritage festivals. But also, we've also started going to ASET Sites. So within a month, I will go to food pantries, to soup kitchens, to homeless shelters, to community agencies, to city libraries, anywhere that there's a chance that there might be people who could use our services. And the whole idea is that I'm in there with my computer, and they can come in and sit down. The past few days I had the heat blasting, so it was good. I was over at Macaulay House this morning, and a few guys came in just to get warm out of the cold and got to talk to them about 211 and see if they had service needs. And it's a great program. So we're all over the place. I have about 25 set monthly visits that I go to, and people are starting to, after a couple of years, they're starting to recognize that I'm coming, and now I go to places and people are saying, oh yeah, I knew you were coming today, so I wanted to stop in and talk to you. So it's really kind of great. But as you can see, it's a big van. I don't need it all myself. So one of the things we started doing was to bring on partners. And I try to work with whoever the site coordinator is to see what kind of partners they'd like me to bring. So I will bring people from our own point program out with me. I will bring people from Child Support Enforcement or National Grid or the SNAP program out with me. But early on in the development of this, we decided that we also wanted to put a real emphasis on bringing health services to the community. So we often will be partnering with people who are providing actual health services right on the van as we go out. I made a quick list of these, so just to give you some idea of what it is that we're doing out there. And the different organizations that help us with that. So we might be doing blood pressure with Blue Cross or Clinica Esperanza or Lifespan Community Health, glucose testing, Clinica Esperanza, Lifespan, cholesterol testing, the same, A1C, the same. HIV testing, there's a very quick test for HIV now. It's a mouth swab. 10 minutes later, you have your decision. And so AIDS Project Rhode Island and AIDS Care Ocean State often will send their outreach people with us, and we'll actually do HIV testing right on board. We can also do Hep C testing right on board. It takes a few minutes. We provided flu shots all over the state this past year right out of the van. The flu shots were provided by Blue Cross, Rite Aid Pharmacy, Lifespan Community Health, Walgreens Pharmacy. We do a lot with nutrition. Blue Cross does a nice job of teaching nutrition to clients, and so does the URI SNAP nutrition program. Child safety. We have a couple of organizations. We have a partnership with Hasbro Children's Hospital, which has a program called For Safety. It's sponsored by Dunkin' Donuts, and they come with us and they teach about child safety. They just finished a whole project on Christmas safety, about lights and electricity and trees and that kind of stuff. In the summertime, they'll be talking about helmets and safety for kids. And we also partner with an organization called Jace the Healer Foundation out of Johnston, and they work on water safety, especially pool safety for little kids. Body mass index, Blue Cross, Dermascan. We do this a lot in the summertime. It's a way to have your face checked to make sure that you're getting enough protection, and if there's a possibility that you may be developing some form of cancer from the sun. We do a lot on disability services. So one of our partners is the Ocean State Center for Independent Living. You may know it as OSIL. Brain Injury Association of Rhode Island comes with us also. We do a lot in health insurance. I already told you we work with the SHIP program. We work with Health Source Rhode Island, but we also work with Child and Family down in Newport doing insurance counseling and enrollment, West Bay Community Action, Tri-County Community Action. We've got a nice new partnership right now with the Rhode Island Office of Veteran Services, and we've been seeing veterans on the van and getting them hooked up through the state office with the federal VA and with the health services that are available there. We work with the Department of Human Services twice a month. I go to DHS offices where I can actually help people sign up for health insurance through their program, and the Rhode Island Vets Corps. Hearing Services, Rhode Island Office of Rehab Services, and the Assistive Technology Access Partnership. Dental Services, Rhode Island Mission of Mercy, another great program that we work very closely with. And Addiction Services, we work with Anchor Recovery, and of course we have our own addiction services for gambling addiction. On the van we have computers, so we can set the computers up so people can come in. We've been doing it on a limited basis with DHS so that people don't have to stand in line at DHS. They can actually come in and do the process right in our van when we're there. As you know, there's some issues there. I won't go into them, but it hasn't been a great success, but we expect it to get better as we go along. And we have telephones in our van, so people can actually call and make the appointment. If I'm talking to somebody and saying, I want you to call Providence In-Town Churches Association and make an appointment to talk about homelessness, I say, here's the phone, call them right now. And that's been a great help to our program. I just said an awful lot in a short amount of time. I'm used to speaking quickly. So before I go into the next section, are there any questions or comments about what we've been talking about so far?
Questions for Jay?
Sure.
I'm curious about the folks who answer the phones, who see people when they walk in. And I know you said there's a database, but because you provide what you've called wraparound services, it's not just a matter of,
Right.
punching a button, having names come up. But I'm just curious what the background of these folks are, because they're dealing with an enormous amount of information.
We have a number of different backgrounds. Okay, we have actual people who graduated from college with social service type backgrounds. We have people who are community based that don't have that level of expertise, but we work with them to bring them up to get that level of expertise. Training is very important to us, and we have a lot of mentoring going on. When I'm in the office, I'll be sitting with some of the newer people and saying, well, why don't you try this, or why don't you try that? So it's we have everything from high school through college, and I think we might even have a master's level person in there right now.
So it sounds like there's a lot of in-house training.
It's almost entirely in-house training.
Okay.
You have to, the way we see it is that it's more important to have the personality that is able, I can train them how to find the services and what services and that kind of stuff, but it takes a special person to be on the phone 8 hours a day with problem after problem after problem coming at them, and being able to, one of our mottos is the 88th call is just as important as the first one in the morning. To that person who's calling. So it's more important for us to get the right person, the right personality to be able to handle that kind of a job, and then we can teach them, and we have the database, which is pretty extensive too. So, yeah.
Overnight, you said it's 24/7. Is it still the local people who answer the phone, or does it go to a centralized?
From 12 to 6, it's answered by the state of Maine's 211 services. Unless we're in the middle of a disaster, then we take it over ourselves. We do a lot of disaster work, too. Many of you know, as soon as a hurricane or a snowstorm or a blizzard or something's coming, and it's going to be a big one after the floods or the hurricanes, the first thing the governor says is, if you have any questions or any problems, call 211. So when that happens, we really all hands on deck, and we work full-time at that point.
Thank you, Jay. Other questions? Yeah, go ahead. Yes.
How up to date is your information? I mean, how often are you updating it constantly?
I didn't plant her.
Or?
I really didn't plant her because that was my next thing I was going to say. It's a big database.
Yeah.
we try to keep up on stuff, but it's almost impossible. Hours change, programs change. So what we did this past year is we've changed the system so that if you call, you get, and you're running a program, and I recommend you do it, you can call and you get a password that allows you to go into your organization and keep it up to date. It's the only way we can do it. So my next comment was going to be, if you know of any organizations, any of the organizations that you are involved with, go to that United Way website that I told you about, look up your own organization and see what it says. Because if it is not correct or if it's not in there, then it's invisible to us. And we can't send you the correct clients, and we can't send you the correct, we can't give them the correct information for them to get the services.
My question was, that was part of my question. The other part was on the shelters, in particularly in the winter. I mean, I've had staff who've called, and I know that, you know, they'll say they're all full. Is that, are you just on the phone constantly with all the shelters? Are they calling in to talk to you about capacity, or?
It's three different answers to your question, okay? Domestic violence issues that come to us, we send to the local domestic violence organization, and we know which ones have space, so we might send them in that direction. Singles, we will give them the list of shelters that are available and tell them a little bit about each of the shelters and where they should go, and give them as much information as we can. Families are a little bit different. In Rhode Island, in order to get into, because the family shelters are all full. So the way the system works is you call 211, and we have a dedicated staff person that does this because the calls are just constant. And they do the intake. So it takes about 20 minutes to do a full intake. And the reason we do the intake is so that we can, as we're talking to them, we might be able to find a way to divert them. We might find that there's something. I mean, they might need $75 just to hold on to the apartment that they're in rather than get evicted and have to go into homelessness. And we might know where we can get them the $75 to do that. So we do the diversion part of it when we do the intake for families. Once the family has had the intake done, they go into the HMIS system. That's the Housing Management Information System. And it becomes a list. Some people call it a waiting list. I don't like calling it that because it gives the wrong impression. It gives the impression that the first person on the list is going to be the next person to get a shot into a homeless shelter, and it doesn't work that way. They are ranked by the necessity, which sounds terrible, but they are ranked. And when rooms open up in the homeless family shelters, they go to that list. In other words, we put the information in, and then we are pretty much finished with it from that point of view. Then the shelters go to that list to choose the families. And I say choose, I don't mean picking and choosing in terms of cherry picking, but they may have a room that's only suitable for a mom and one child. And the first person on the list might be a mom and a dad and 5 kids. Well, they can't take that person. They'll have to take the next person that meets their requirements. And that's why it's really not a waiting list. It doesn't automatically mean that you're at the top of the list. It's going to depend on what opens up in the shelters. It's not a good system. I mean, it's a great system, but there's not enough shelters, so we constantly have families that are without emergency shelter.
If you want to continue, because another item we want to address as well.
When I was asked to come, I was told to bring any concerns or any ideas I had. So I've just got a couple. One is that over the past 10 years in the community, we've seen the entire safety net start to develop holes and get worse for clients, especially clients in needs. One of the things that we've seen about it, and I already gave you full disclosure, I used to be a social worker for the state, is there are no more social workers out in the field. They're very few and far between. There are a lot of them that are clinical social workers, but there are not the old-time social workers who could take on a client and stay with the client and help that client get to where they needed to be and get the services that they need. As times have progressed, that whole process of having a social worker has changed into having people who were case managers or were eligibility technicians. And it just is not the same skill level, and those people are also overloaded with the programs that they have. And so what we've moved to is telephone and computers, too. And 211 has moved along with that. But, you know, at the Department of Human Services now, they're pushing people to go with computers and with phone banks. And everybody knows that when you call for service these days, you're going to get into a phone bank, and you may or may not get the service that you need. So I would just recommend, and what has also happened because of that progress is services have been fragmented. So I might call somebody for a service, and we've got great partners in the state. They're great organizations, and they know everything they need to know about their programs or their arena, but they don't know the other programs. And that causes the system to be even more fragmented. 211 tries to overcome that by knowing all of the programs and all of the systems out there. But it's a big task, and for people who don't call us, they get stuck into a situation where there's no one helping them. I think we need more helpers out there. We can talk all we want about literacy for seniors to apply for programs on the computer, but it's not going to happen. And so every month I spend part of my time in the van sitting down with seniors and others, not just seniors, but sitting down with people. And I did it last Thursday. I did a SNAP application on the van with a gentleman who had to apply for SNAP. And he just said, I don't know where to start with this. I don't read well. I don't know what the questions mean. And so there's not enough helpers out there, and there are not enough helpers that have a full understanding of the system. There's a lot of people out there that know their program. I'm not going to denigrate that. They're great at it. But another example that I use is that I talked about having healthcare providers on the van. Well, I've been in situations on the van where they were doing glucose or A1C testing, and then the nurse practitioner or the nurse was there and said, oh, you're really high. You really have to start watching your diet. And the person says, well, that's nice of you to say that, except I don't have enough money for food as it is, so I really can't be worried about my diet. That's where 211 comes in. The medical person, who could be the best medical person in the entire world, can say, I know nothing about how to get this person more food, but Jay does, and 211 does. So trying to bring those pieces together and having actual helping people out there. Many of the people we're talking about, not only seniors, but whether it's a language problem or a cognitive problem or an emotional problem, they need that. There's got to be a place for some hand-holding and some actual help for the clients. The other thing I recommend is that we talk to our service providers. They are so overloaded with their own work these days that they don't have enough time to do like 211 does. So they do know their programs, and they do know what they're talking about when it comes to their programs. But with a little bit of training and a little bit of outreach by their organization, if the organization recognizes it as a priority, they could be trained even further so that that nurse practitioner might know a place to go to get food or might know a little bit about the food stamp program. But that takes will on the part of the organizations, and some of these are really large organizations, and they need somebody to have them help get the will to spread out some of that work so that the people don't fall through the cracks and that there's less fragmentation of the system and less siloing of clients. And that was it. I've brought a few 211 flyers that are here, and every year on February 11th, it's 211 Day in Rhode Island. It's really cute because February 11th is 211. And we are starting to put together, and we'll be back up here on February 9th, which is not 211, but nobody else will be here on 211. So, and we've started putting together a fact book every year. This is last year's. I couldn't bring one for everyone because we only have 10 left. Because there'll be a new one out next month. But I'm going to leave these on the table also. and your staff here has a copy of it. So if you need actually more than I'm leaving, she can make a copy of it and get it to you. But it's very interesting about where the calls come from, what the calls are asking for, what the services. We've had an exponential increase in calls for food services over the last year. It's been off the charts, and we'll know this year what the 2016 numbers are like. We'll know in a couple of weeks.
Okay, thank you very much. Good. Good.
I'm just curious. I'm sure in all this good work that you're doing, you've run across deaf clients before.
Yes.
And I'm wondering, what would be your approach to be able to communicate with them or to help them get the resources they need?
I work very closely with OSL, and OSL will send an interpreter. And also, we work with the adaptive, I forget the name of them. I know them, but I forget their program name. It's the adaptive, where are they?
You have a system.
Adaptive Equipment, Assistive Technology Access Partnership. I work with them. And, of course, on the phones, we have TTY and all those different systems to help us work with people who have hearing issues.
Do you have a video phone access at all?
Not yet, no.
Thank you.
Thank you, Jay.
You come up with a grant, let us know.
I'd just like to thank Jay for being here. I've been on the 211 van with him quite a few times and see the work that they do day in and day out. Mostly being from elderly affairs, we obviously focus on the older adult population, but they're serving a lot of people every day. And one of the things that United Way and the Point does, as well as our Point partners that Jay spoke briefly about, who are located mostly at senior centers throughout the state. They perform those SHIP counseling services, which is Medicare counseling. So they are assisting older adults in navigating that really difficult process of picking the correct Medicare plans, the correct Part D plans, looking at drug formularies, which is all online. And a lot of seniors cannot do that, nor can even their caregivers do that. So the work that the Point at United Way has done and our other partners actually led to Rhode Island being named as the second best SHIP counseling program in the country.
Didn't know that.
For the 2016 plan year. So congratulations to you and all of our partners in the community.
Yeah, we take it very seriously. We try to, our number one goal is to save them money and get them into the best plan we can. And one of the other issues with Medicare is there are programs out there to help low-income people pay for it, and they just don't know that those programs are out there. Again, they're computer-based. They're a little bit difficult, so we work with them on getting all that stuff done, too. Thank you, Megan.
Okay, thank you very much. Is there one last question before we move on?
Jay, I want to thank you for you and the staff at 211 for all that you do. I have a question, and my question is, when 211 makes a referral to a community case management agency, as we know, some are better than others, and I've been in public health for a long time. I'm out in the community. And with the shortage of social workers, what is happening, as you point out, things are getting lost. People are getting lost, and services are fragmented. You call one case management, they don't know. They put you on hold. I'll call you back. You don't get. These are the complaints and problems I deal with. So is there a mechanism to follow up if 211 makes a referral to community case management and that person is directed there, and where's the follow-up? I mean,
It depends. If you're talking about the Point community case management, we always ask the people to call us back if they run into a problem.
Right.
And we do that with 211 also, but in this particular case. And if it isn't working, we've had one recently where it just wasn't working. And we will reach out to that organization and find out what the thing is. I mean, we try never to bring it to the next level, to the DEA level. We have in the past when we've had problems, but we try never to do that. We try to work with them and say, geez, we sent this person over to you and it seems to have fallen through the cracks. What's going on? It's all personal contact. I mean, it's not forms and that kind of stuff. It's the guys at the Point or me or whoever calling somebody and saying, geez, we got a problem here because we got a client that isn't getting serviced. What can we do about it? We may find out that we made the referral incorrectly, and then we'll do what we have to do to straighten that out. Or maybe they're overloaded and they really didn't tell the client they wouldn't see him. They probably told him, I'm going to see you in 3 weeks or something like that. And we can help interpret that back to the client also at that point.
We're all in the people business, but sometimes we lose our people along the way because of fragmented services.
Yeah, the third and fourth thing that I do with outreach, I mean, we talked about letting people know about 211 and letting people get access to the 211 service in their community or wherever they are. The third and the fourth thing I do is when I bring my partners out, I always introduce them around to the service, to the site. So today we were at Macaulay House and I had the caseworker from the state's Office of Veterans Affairs. He didn't know about them. They didn't know about him. Now they do. So we're working hard to try to bring those connections to the communities as much as we can.
Thank you, Jay. One last question on the end.
Thank you for coming today. The question I had is around the 79,000 calls that you get for health-related issues. Do you have an estimate or a ballpark or just an instinct as to how much of that is due to folks not understanding either their health insurance, understanding what doctor they should be calling, understanding health in general and what's determining their health versus I have a specific issue or a specific illness and I'm looking for either educational resources or other things on that, because I think that that gets to a little bit of what the commission's looking into and or whether or not over time you'd be able to flag those calls in that way. So it would be sort of a data source for us when we're thinking about health literacy. And maybe you would have a better instinct of when you do these three-way calls with, you know, an entity and an individual, do you do them with providers? I mean, because they don't understand how to take their medicine or something of that nature.
Right.
So I'm just interested in any information or gut instinct you have on that.
It's going to be gut instinct because I don't have the stats, although with the proper request to the powers that be at 211, maybe we can work some of that out. I know that the statistics that we collect are more in depth than the numbers we give out on this book because it's just it makes more sense to give out the congregate numbers than the specific ones. I would say about 10% of the calls are disease specific. I have diabetes now and I need to know what to do about it, or I need to know what doctor to go to, or probably 80% of calls are for health insurance related in some way, whether it's I need health insurance or the health insurance I have isn't helping me and I need additional resources, or I need, and I count this as health insurance related. When somebody calls me up, I had one the other day, I need, I forget what it was something that they needed. I said, well, go to your card. I said, who are you insured by? And they told me. And I said, well, go to your card, pull it out. And they pulled it out. I said, see right here, it says member assistance number. I want you to call them because they can tell you who to go see. So I count that as an insurance question and not as a specific disease-related question, because all of the insurance companies in the state have some sort of system to help their customers, patients, find the services they need. But about 80% of our calls are in that realm.
Hey, Jay, thank you very much. Just one comment, if I may. So thank you for what you do. Obviously, 203,500 plus calls and 79,000 plus associated with health-related. That's a lot of calls. Start doing the math of how many per day, how many people you need, how long those calls are, and I said, I realize you're 24/7, but I would suspect most of those calls are coming in somewhat of a 12 or 10-hour period,
yep.
Monday through Friday probably. So
weekends get a little bit heavy.
I'm sure you do, but I'm saying if you looked at the distribution of those calls, they'd probably be heavy during those times, the number of people to address that. Not so much for today, but I would ask you to think about, and I'll follow back with you. So what, in some regards, 211 is doing is addressing the symptoms of a much larger problem, I'll call it. It's, in an ideal world, I'll say it, we wouldn't need a 211, right? In an ideal world, things the way they're printed, things the way they're communicated, things the way they're advertised online, or however the information is communicated would be, I'm going to say, self-explanatory. Maybe I'll say would be self-explanatory for the average Rhode Islander, the average individual. I don't know what an average individual looks like, so it's hard for me to articulate that. But Great. So some of these calls are for folks that are in maybe at wit's end on some things, so they don't know where to go. But just talking to somebody helps that. So maybe a portion of those numbers, of those fraction of that 200,000 or 70,000, can just be not disregarded, but taken out of the mix of those calls are going to happen regardless of whether information is clear, self-explanatory for somebody with an X degree level education, et cetera. So if I can follow back with you in the future, in a couple weeks, it'd be important, I think, for 211, if you don't do it yet, to gather the information of the call. The call came in because of this. We've had 10 of those. How is that fed back to whether it's a provider, a state agency? I'm not indicting anybody.
Right.
I'm just saying, how are we helping that as opposed to continue to address the symptom? And if we don't address the root cause, the symptoms will continue. But if we can address that root cause of, we got 15 calls or 200 calls on this, this is a problem. What are we doing about it? That could be the case for, say, some intervention on the preventative side, where there's some investments required to say, let's go help that, because you know what? Those 200 calls, maybe be 10 in the future. I'm making stuff up, but so I'd like to follow back with you to see how
I'd look forward to
the facts
it,
and data and evidence can help drive us so that we.
And we do some of that, but we're not a state organization. So we do it. One of the ways we do it is this: we brought this to everyone's attention that food insecurity in Rhode Island was going up now, and part of United Way has an advocacy role, and they take our information and use that. But I think it could be enhanced a lot more than it is.
The case with regards to food and what was the other piece going up? Food and
food. That's the only one I mentioned, but.
Food and subsistence need for that going up. Well, one could say, let's get more food. Well, we need to do that, but that's the symptom. What's the real cause of why more food is needed, right? Like I said, being respectful about the conversation and the situation, how do we go back to the root cause of the problem and invest there as opposed to, let's bring more food in? Well, it's the
we're always willing to work with data. I mean, it's a big thing at United Way that the programs that United Way supports are data-driven. I mean, they're not just because they think it's a good idea. So we'll be glad to work with you, Senator, at any time to go forward on that. And I'll leave my business card with her before I leave.
Thank you very much, Jay. Much appreciated. So the next item we have on the agenda, I think we're going to start it. It's 3:25 now. We may begin it. I promise the goal is we're done within an hour and 15 minutes, and we'll come close to that. We have one other item to address with regards to our next meeting. And we had asked folks to, and thank you, Kat, for doing this, and thanks for your preparation for this, much appreciated, to look at the priorities that each of us have identified. Some may be filling in for somebody else, so I appreciate it. We appreciate that as well. With regards to the rationale for the priority, is it still a priority based on what we've heard over the last number of meetings? Should some of these be changed or whatever? And I'm a firm believer in staying on time, but I'm also a firm believer to make certain that we're not going to cram a whole bunch of stuff into 10 minutes that's going to take, or 15 minutes that's going to take 45 minutes or an hour to accomplish. So if some folks have, I appreciate the folks that have looked at this already, so if you haven't, you've been given a reprieve. I won't call on you individually because otherwise I would have called on everybody individually, even if your name wasn't on here. So if anybody has some thoughts, comments, we'll be open to, at least probably for 10 to 15 minutes, we'll do that, and then we'll continue. Any takers? Yes. Sure.
Maybe guess.
If you can identify yourself as well so everybody knows.
Yes, I'm Mary Perella, and I'm here representing Department of Education. And
That would be RIDE. That would be RIDE.
Yes. And I work in Pawtucket School Department in a community school environment. So I looked at this list and looked at some of the folks that we have had come in and trying to figure out like what it is we're actually trying to do. So I think there's a couple of different parts of this. And I think part of it is that we are, if we want to try to help, is how to get the word out and to make sure that people are helping people understand health literacy. So there's, the part about being clearer and making things simpler, as you mentioned, making it clear and easy to read. There's the resources like 211, but there are many organizations that are in some way doing wraparound services, trying to do them within a particular functional area, if you will. And so I think that the groups that really need to be targeted are the community groups like the schools, like the child opportunity zones, community schools, the adult education programs, the health equity zones, and then other key community partners. Those are the ones that I'm most familiar with. And I know that parts of this goes on, and I think if there was a focus on it to make sure people understood, because until you stop and say, well, there's a commission looking at this, and you read the materials, you either take it for granted or you just know it's a problem. So I think those are potential opportunities of organizations just that that are referenced in here and that I'm familiar with that could get that word out and help to educate the public better on a whole host of those issues. So I think that would be an easy way to incorporate that. I think there's, as I looked through the comments that people had made, there's one common theme was common health care language. And that seemed to be something that ran throughout, and it probably is something that is much needed because we need to make sure we're all talking the same language, and if we're going to help educate people to understand it, we have to be clear what it is. And then I think the other thing that struck me in looking at the materials again was understanding another area that a lot of people made reference to was people understanding their financial responsibility, a lot of it around insurance and what the insurance is actually saying and what their responsibilities are. And then I don't think you can overlook the mental health issues. When you talk about health literacy, it has to be physical and behavioral health as well. So those are just some thoughts of me looking back through this material before I came here today.
Thank you.
Okay. Steve? Yep. Thank you, Senator Palmer. Steve Bernero, I'm the Executive Director at the Rhode Island Parent Information Network. Incidentally, we also have a couple of call centers at RIPEN, including RIREACH, where we help consumers of health care, and also we are the Parent Training Information Center. So we have a unified call center, and we get approximately 2,000 calls each month around health care concerns in addition to what 211 does. But we do a little bit more intensive case management. We will actually represent families if they feel that they needs health benefits that they're not receiving. So it's a little bit more intensive than the referral system. But, you know, it's ironic that we have health literacy and patient engagement as agenda item number 2 because we've been talking about the need to establish patient engagement practices in a consumer advisory body. And incidentally, HealthRight did an analysis a couple of years ago. Betsy Laux, who's a consultant for RIPEN, and Tina Spears, who actually now works for the Senate. There's a page 10. It talks about where are the patients in the policy conversation. And patient engagement is very necessary at the policy level. However, there are many obstacles to patient participation in policy conversations. In Rhode Island alone, there are well over a dozen different meetings where a member of the public could participate and comment on the future of health care. Even for a very engaged member of the public, it is difficult to determine where one's time and energy is best spent. Consumer advisory committees are one strategy that we feel that would help to create a space reserved for consumer input, and Rhode Island should consider investing the time and effort in re-engaging consumers in these efforts. So I would go back to our initial recommendation around trying to coordinate the patient involvement, patient engagement in a consumer advisory body that is person-centered, culturally and linguistically appropriate, is disability sensitive, and really addresses the needs and care for services through informed decision-making in Rhode Island. So we would continue to emphasize that as a priority for Rhode Island.
Steve, thank you. The HealthRight piece that you mentioned, can you provide that electronically at some point to Kat?
Yep, I sure will.
And we'll get it off to
Send it over
everybody,
to
and we'll
you.
get it online
Yep.
as well.
Tara Provençal from the Executive Office of Health and Human Services. So I wanted to follow up on that with the patient engagement. That was one of the things that I brought up as one of my priority points is, again, to also establish some sort of healthcare language, establishing the same terms, definitions, so that everybody is speaking the same language, but then at some point you have to have that communicated, and patient engagement is very important. One of the bigger areas I think that we could start would be in the provider offices, so that the providers can explain healthcare to their patients appropriately, but in that way they would understand their treatment, their diagnosis. One of the things that I wanted to bring up was, as Senator DePalma or Chairman DePalma mentioned earlier, was SIM. SIM did present to us, and they talked about a patient engagement request. I just want to give an update that has been released, that is on their website, and they're asking all Rhode Island nonprofit organizations that are interested in applying for SIM funds to carry out this health literacy and health education activities to apply under their RFP. So that is on the SIM page, which is on the EOHHS website. And I think to carry out this priority, SIM could be an asset to this group. I think it's extremely important in order for this commission to carry out anything that we need to just reach out to the resources that we have around us.
Sarah, thank you very much. And Kat, we'll get that link to everybody as well. Good?
Jay Garrett with the Office of the Health Insurance Commissioner. And I agree with a lot of the topics. The topic of, or the concept of common definitions is a good one. The only challenge with that I see is that there is a lot of different statutes, be them federal or state, that define health insurance terms specifically differently. But it would make things a lot simpler if we had a kind of a common depository of health insurance terms. But from the office, from the perspective of the Office of the Health Insurance Commissioner, it's been brought up, and there's an important need for consumers to understand their health insurance documents, describing their benefit coverage, their exclusions, their responsibilities, and how to access their care. Many consumers don't understand these documents because they're complex and very technical. And contributing to that is the literacy rate. In Rhode Island, was reported in 2005 by the Providence Journal that 47% of Rhode Island adult population reads at a 6th grade reading level. The Office of the Health Insurance Commissioner, we review the forms, the certificates of coverage, the summaries of benefits, along with the rates each year for all the plans. And as part of that review, we have a Regulation 5 that requires the text of the policies, certificates of coverage, those subscriber agreements, those summary plan descriptions, that they don't exceed an 8.9 grade reading level as measured by a Flesch-Kincaid measurement scale, which is a tool that basically abstracts a text and judges it on grade reading level. Those forms that are filed, the insurers have to attest through a signed readability attestation that they meet that level. One of the rate approval conditions that OHIC imposed on the health insurers for the 2017 rates, which were approved last summer, going forward, requires issuers by March 1st of this year to submit to the Commission a report on the issuers' efforts to improve their readability of these documents, summary marketing materials that explain key coverage points. So based on this review going forward of the efforts made by the insurers, OHIC is considering lowering the reading level for some of these documents to a 6th grade reading level by Flesch-Kincaid. So I looked at, considering all the priorities that were presented and my focus on health insurance, I thought that was, something that is attributable and possible to do in the near future.
Thank you very much. Much appreciated. one last one, and then we're going to move on, then we'll reconvene with this topic. Good.
Chairman Amanda Barney with the Hospital Association of Rhode Island. I just wanted to echo Jay's comments about patient financial liability because the burden is growing as we see co-payments and deductibles increase. The stakes are getting higher, and it's important that Rhode Islanders are understanding the purchases that are being made for these insurance plans, and then understanding how they're utilizing the services. So, in making the best decisions for themselves, for their health, both their physical health, mental health, and financial health, whether they're seeking services in a physician's office, an emergency department, and understanding what the financial ramifications of that are.
Yes. Go ahead.
One quick thing, and that is, I think everything that's been stated is all important pieces. I think I'm almost thinking like there's a micro and a macro version of this, because some things are very, very specific, and yet there are all these community resources, the ones that I had mentioned, through education and HES and all these community groups that can begin to work on those same issues with population before they're in any kind of a crisis, or as they're going in to look for insurance or whatever the case may be. So I just think we need to look at it from different perspectives and at sort of different levels of our viewpoints.
Thank you very much. I think we're going to move on to the next item. I do want to reconvene. Like I said, the next time we meet, we will. I know who hasn't spoken, and if you have spoken, you can speak again. I will allow you at least one more time on the topic. But the next item on the agenda, we had two more, was a date for our next meeting. And thinking about a month from now, if that's the, I don't have a calendar, I have a calendar, but the President's Week would be, I'm not sure if that's President's Week or not. School vacation week, for those who might have children or grandchildren. I have one of those now. So.
That's the week of the 20th. That's the week of February 20th.
That's school vacation week.
Yes.
So what's the second Tuesday in February?
The 14th.
Valentine's Day gift, if you like. Is that a good day, or would you prefer not to meet on Valentine's Day?
It would be this time before the session, right?
Correct. Or maybe 6:30 at night we would do it. No, just kidding. So if 2:30 on the 14th works?
Yeah.
So 2/14 at 2:30. We'll confirm that with everybody. There may be we may need to meet at a different place, but we will certainly confirm that and modulate the date since the General Assembly's back in session and there might be hearings. The last time we had on the agenda was public comment. If we had anybody from the public who would like to comment. If there are none, if there's a motion to adjourn, I'll entertain a motion to adjourn.
Make a motion to adjourn.
Any second? I assume all approve. All in favor?
All right.
Anybody opposed? Thank you very much. Much appreciated. Thank you.